Senator Givens,
Here.
Senator Neal, Senator Nemus,
Present.
Senator Webb, Vice Chair Bledsoe, Chair McDaniel.
Here. Very well. We have a quorum duly constituted to conduct business. We'll go ahead and get rolling. First up, start with Medicaid nursing home rate rebates program. Adam, I think you're up. John, you up? Let's do it. All right, gentlemen, please go ahead, introduce yourself for the record, and proceed.
Sure. Adam Mather, president of the Kentucky Association of Healthcare Facilities and Kentucky Communities of Assisted Living.
Hi there, John Muller. I'm the Chief Operating Officer of CareSpring Healthcare Management, and I serve on the board of Kentucky Association of Healthcare Facilities.
Very good. Please proceed.
Thank you so much. Well, we certainly want to thank you all for letting us present today. I'm going to try and pull up the PowerPoint for you. So I'm a visual learner, so the first two slides are going to give you a little indication of where we stand in the healthcare sector as opposed to our other partners along the continuum. So as you can see, we've had a serious slow job recovery in our segment. We are still down over 131,000 workers nationally, and this state is no different from others. We're experiencing significant shortfalls ourselves. And you can see that compared to our other segments, we're considerably down. So, we're struggling to compete for workers just like every other healthcare segment of the continuum. We've experienced the worst job loss in the healthcare sector. We've spent significant amounts of our money on wage reimbursement, on wages. We've increased on average nationally 17.3% since 2019. And our wages continue to increase, and they're outpacing other entities within the healthcare continuum. 9 out of 10 nursing home providers have increased wages and offered bonuses to try and recruit and retain staff. But it's still considered one of the biggest struggles that our nursing homes have to face on a daily basis. So statewide, there was a Kentucky Skilled Nursing did a financial distress test. 79.9% of facilities are considered in financial distress or at risk of financial distress. Many of those are in rural communities where they are the largest or second largest employer, and the nearest nursing home would be 2 or 3 communities away. Cost of wages, as I mentioned, has skyrocketed, and John can further elaborate on that as well. Maybe share some of your current changes would be helpful, I think.
Right, so we provide support for operations in Northern Kentucky. We've got four nursing facilities and an assisted living in Northern Kentucky, Campbell, Kenton, and Boone County. So we're urban, suburban, but it's just the matter. The cost reports. Sorry, is that better? Thank you. So the good thing about we're a very transparent sector. Medicaid cost reports are produced every single year, all across the state, all across the nation, and the cost reports are real. They're no projected losses. It's no projected occupancy. It's really what we spent. I mean, it is really and truly what we spent, and we all have experienced the inflation. But it has just really come home in our sector, I think, as Adam pointed out. The job loss in our sector is the only one to not get the jobs back to pre-pandemic level. And that is also, it's just the facts of the matter. So our routine costs have gone up 35%. So that's food, that's the insurance, those are the other routine costs that go into the care. And our direct expense, which is the care, has gone up 60%. And again, proven out by the cost reports, not any projections, and a lot of that is because we haven't rebased. So this is a long-standing concern. We haven't rebased since 2009. So moving the can down the road, I think COVID it showed of any area that had a real stress opportunity was nursing facilities. So This rebasing has been something we've worked hard on over the last few years. We've worked hard in the interim. It was in the House's initial budget, somehow came out of the budget, and that's what we're here today to talk about, having it back in.
Yeah. So just to give you an idea of the landscape of each facility, so about 76% of the residents rely on Medicaid as their payer in Kentucky in nursing homes. And so that is the vast majority of the reimbursement that a facility receives. And so what we're asking for is, Medicaid is rebasing, which really aligns the standardized price or the cost or to reimburse for the cost of care. There is no additions in there. And I think what's stunning is the last full rebasing that's happened in the state of Kentucky, which it was supposed to be every 4 years, just didn't happen, or the last time it happened was in 2009. This gives you what, in addition to the rebasing, one of the legs of the stool is the inflationary Medicaid rates. So they'll create a inflationary rate to adjust for the next year. As you can see, many of those are 0.1% inflationary rate. I've lived in Kentucky since this chart is from fiscal year 2010, and I don't think that we've ever had an inflationary rate below 2%. So as you can see, there was an adjustment done in 2024. They used the IHS, which is a global insight. They track and produce the actual inflationary rates. So they used that and made the adjustment, and we're very appreciative of that because it hadn't been adjusted in a fair market value with any type of real inflationary basket to go from. So very appreciative of that change. And then here's what we're asking for, which is, or the rebasing needs, which are $220 million in fiscal year 2025. So that how that breaks down is there's a state general fund dollar amount and then the federal match for that. So 62.5 in general funds would be needed, and then $157.5 million in federal funds would match that 62.5. Then in fiscal year 26, 235 million total, and 67 of that would come from general funds and 168 million in federal funds. And our ask is that the rebasing gets fully funded for both fiscal years 25 and 26. This ensures, baseline funding is adequate for the Medicaid program, and we can deliver quality care to the residents that we serve. And then we really appreciate the collaboration and certainly want to ensure that going forward that we continue that work with the General Assembly. It's been really nice to meet with you all and have those discussions and share our vision and mission for long-term care and our struggles. And with that, I thank you all for your support, and I certainly open it up to any questions you may have.
Thank you. Adam, real quick, go back to slide 5, please.
Sure.
How do you define financial distress or at risk for financial distress?
So this was done through the Z-score, Altman Z-score, and so these are facilities that are going to go potentially out of business within, I think, 12 to 18 months, I think. But Senator McDaniel, I'll get you that exact information. So you have it.
Thank you. And go to slide 8, please. There you go.
Which I don't know.
Okay. So in each of those fiscal years, governors in the House, they're in or not in?
They are in the, and I think the cabinet can elaborate further on this. It's they're both in. It's the baseline Medicaid budget is not fully funded in the Houses.
Is that for both years or just 20?
Just for 25.
Just 25. And how much shortfall do you think there is in general fund?
It will eviscerate any rebasing for 25 for us completely.
Okay, good deal. Other questions? All right. Seeing none, thank you all very much for being here.
Thank you so much.
Appreciate it.
Thank you.
Okay. Next up, Medicaid funding sources, Secretary Friedlander et al. What's that? Gentlemen, if you wouldn't mind, identify yourselves for the record and proceed.
Thank you, Mr. Chairman. John Hicks, State Budget Director.
Eric Friedlander, Secretary of the Cabinet for Health and Family Services.
Steve Bechtold, Chief Financial Officer for the Department of Medicaid.
Very well. Before you guys start, I want to say it publicly. Secretary Friedlander does a great job. And he's not just a high-level person. Of late, I've been able to see him getting some very granular, very individual details to try to help some folks in hard spots. And I just wanted to say personally thank you, because you're definitely working at every level, all the way down to the individual, and it's appreciated.
Thank you.
Mr. Chairman, I know we're going to be mindful of time today, but we wanted to, and so we've got probably more slides here than we'll go through in detail, but there are resources always to be able to go back and look. So I'll turn it over to Secretary Friedlander to start.
Very briefly, this will be a slide for your all's reference. These are sort of the biggest pieces of how we have payment and revenue, and so just want you to see that as we go through the rest of the presentation.
So Medicaid is a joint federal and state program. It's funded by state funds and federal funds. The state funds are either in general funds or in state restricted funds, which has to be supported with the agency cash accounts. In our projections, and what was used in the governor's recommended budget was the federal and state split, using those down at the bottom. You'll see the blended federal match and the state federal match. I will point out federal match rates are on a federal fiscal year, which is October through September, and we had to do this and blend it to get to the state fiscal year. So 3 months at one and 9 months at the other. That's how you get to that blended rate. I will point out that the enhanced FMAP from the public health emergency has been phased out. It ended in December 31st of 2023. And I just wanted to make mention that during fiscal 23, the traditional FMAP was $78.95. So you could see there's a drop in federal match, which means in the future, the cost of doing business for the state is going to increase.
And I would just add, Mr. Chairman, that in the main, all states got an additional 6.2% to their federal share of Medicaid, and that lasted for several years now. And so every state's budget is now contending with two things there: the expiration of that extra 6.2%, and then the redetermination of eligibility, which we'll touch on a little bit later. This next slide, I won't try to go through. There are 3 or 4 areas where for years the state agency responsible and the Office of State Budget Director have gone into significant forecasting processes. The prison population forecast, the forecast of K-12 school-age children, and property valuation for the SEEK formula. We work with the Department of Ed. We work on probation and parole caseloads, and we work with Cabinet for Health and Family Services in the Medicaid Department on trying to forecast the Medicaid expenses for the upcoming biennial budget. It's a very significant and intensive effort. A lot of work. I've got a PhD economist who leads our effort, along with our analyst, along with Secretary Friedlander and Steve and his staff. Just want to let you know, and they go through weeks of efforts of trying to forecast, and every estimate is wrong, but we try to minimize the error of an estimate when we're working on the budget. So just wanted to let you know that the intensity and the effort that goes into forecasting enrollment, forecasting rate cells in managed care organization, reimbursement rates, all those things go into the machine, and we come out with an estimate. Then we combine it with a cash model to try to determine what is the amount of expenditures that are going to happen when. Then we tie it up with the other sources of funds, which we're going to get into, that make up the state's share of Medicaid.
So I just wanted to point this. This is for the last 3 fiscal years. You could see about 6 provider networks make up about 91% of our spend. And that's hospital, physicians, pharmacies, federal qualified health centers and rural health centers, the 1915C waivers, and nursing facilities. So you could see in fiscal year 23, our total expenditures was $16.5 billion, but we paid $15 billion to those 6 provider networks. And that's through fee-for-service and managed care. So I just wanted to point that out.
And the only other piece that I'll add to this, you see the hospital line and the pharmacy line. Some of those are much bigger because of ATRIP, inpatient and outpatient that we collaborated with you all in the General Assembly to do for the hospitals, and I think it's made a tremendous difference for hospitals, particularly rural hospitals, to stay open. And then the pharmacy piece, we really worked again together. Senate Bill 50, I think the first year I was back, and been a lot of benefits to that, but in particular to pharmacies. And there certainly have been some recent stories about some of the struggles of the independents, but they wouldn't have got to this point if we hadn't worked together on that. So thank you for that.
And that being said, I do want to point out on the 1915C waivers, you'll see a huge increase in 23. That's due to the House Bill 1 implementing the 10% rate increase, as well as the 50% increase that we were advised to do in House Bill 1. We'll be doing another 10% in 24, so you'll see that number even go up higher in fiscal year 24. In nursing facilities, I'll just point out in 22, the big increase there, that was for the $29 add-on that we put in for the public health emergency situation for their PPE.
Good deal. And obviously it goes without saying, your numbers are inclusive of all fund sources.
Oh, yes.
Yeah, that's right. Next slide here shows within the Medicaid budget forecast of eligibles, you can see the line graph is probably the most instructive. That shows you kind of on a monthly basis what the actuals have been through late last spring, and then the forecast is the blue line as we move through the end of fiscal year 26. Well, you can see the decline, right? That's the effect of redetermination from the public health emergency, which is now 9+ months into that effort. So you can see that the budget forecast in the governor's budget incorporated this decline in enrollment, and you can see by the end of the summer we get to a nadir, we get to a low point, and then a forecasting forward of enrollment with a marginal, slight increases. So you can see, we went from nearly 5.5 million people down to 3,375,000, and so far we're fairly on target in terms of the timing and the amount of the disenrolled Medicaid eligibles through that redetermination process. Up on top of the graph is a table. The table shows, in essence, the fiscal year averages of that line graph. And you can see that from fiscal 24 to fiscal 25 in the first column of managed care, you can see about a $42,000 drop. And then you can see the slight increase as we move out of redetermination and into the second fiscal year. So wanted to let you know that we've incorporated these enrollment numbers in the budget forecast. And so they've already been taken into account. We've heard some statements about the House's budget maybe contending that reduction wasn't fully accommodated in the estimates, but I'm here to tell you that they were. I'll open up on this. Now we're in the budget here. You had asked us to talk about financing sources, particularly we wanted to focus on restricted funds because that's not as well known. It's still a fairly large share of the state share of Medicaid. And we wanted to show you in a budgetary view. Primarily, the first number on the page, and then Steve will go through some of the details here. You can see the beginning cash balance of the restricted funds in the current year we're in, fiscal 24, $695 million. Never seen a number like that before. Why did it happen? Because the Fed stepped in with an additional 6.2 federal share of Medicaid is the primary reason. So what we've done in managing through that within the budget you enacted for the current biennium is we basically have banked some money that we knew that we're going to then deploy as we moved into the future. And that's what this budget does. It takes those funds that we built up, basically uses most of them in the first fiscal year of the next biennium, because we didn't want to use one-time money in the second fiscal year of the biennium. We wanted a structurally balanced Medicaid budget in fiscal 26 so that as we move into the future budgets, we're not in a hole when we start that. So that's really key to understanding, but I'll ask Stephen and the Secretary to walk through some of these rows.
So I'll just say that Medicaid cash is generated two ways: provider taxes or intergovernmental transfers called IGTs. That's the only ways that we're bound by CMS and federal registers. That's the only way that we can receive cash funds other than general funds. So you can see there, we've listed out there how much we have projected to receive in provider taxes. That's to your we have hospital taxes, we have nursing facility provider tax on ambulance, provider taxes on SEL providers, we and home health agencies. We have a variety of different ones, but they're, again, per federal register, there's only certain amount or certain provider networks that we're allowed to do a provider tax on. So that's what's on that line there, provider taxes. Hospital rate improvement program, that assessment, that's also a tax. We call it an assessment, but in the form it's a tax on the hospitals to fund the ATRIP program. We have to maintain a maximum of 6% on federal taxes. That's all we can go up to is 6% of the gross revenues. And so we have to take that in consideration when we're looking at the ATRIP and provider taxes. So there's a test that we have to do with CMS to make sure that we are below that 6%.
And guys, we're going to end up against time before
Okay.
it's terribly long.
And then the other ones is university-directed payments. The 1% assessment is on managed care and Kentucky Access Funds, as well as other IGTs. But like Budget Director Hicks said, we budgeted to spend all of this cash by the end, and what's in the governor's recommended is to spend this cash over the biennium.
Next slide. So here we're going to identify some concerns that were in the adopted House budget. First, on Medicaid current services, and by that I mean, what is it going to take to continue the program as